Hello everyone. I, Dr. Seema Tandon, Deputy Director RRTC Program, welcome all of you, especially Dr. Vinita Das, who is the ex-HOD and Dean of KGMU, and all the participants who have taken out time to attend such an important session on anemia in pregnancy. In our life of doctors, anemia in pregnancy is a very important topic, and we are lucky that Dr. Vinita Das, an expert, will be taking this session. So, Vinita ji, a very warm welcome from the RRTC team. Please go ahead.
Good afternoon, Seema, and all the participants. Okay, so today we'll be talking about anemia, and you all know that this is one of the commonest medical disorder we come across during pregnancy. So it is very important whenever a pregnant lady comes to evaluate what is hemoglobin. Then we'll discuss what are the presentations if the patient is anemic, and then we'll do brainstorming with the case presentations. So this is how we'll go about with the today's presentations. We have already discussed the pre-test and the answers. Let me start with what is anemia. I think everybody knows what is anemia, but for the definition, during pregnancy, if the hemoglobin level is below 11 gram %, then we call it as anemia. It is different from the non-pregnant state. Because of the hemodilution, the cutoff of hemoglobin is less during pregnancy. In a non-pregnant state, it is 12 gram %. And if the hemoglobin is less than 7 gram %, then we call it as severe anemia. So we all know that it is the commonest medical disorder, and the prevalence is very high in India, to the tune of about 50 to 70%. And the commonest cause for anemia during pregnancy is nutritional anemia. And among the nutritional anemia, iron deficiency is the commonest. And it is a very important contributor to the maternal and perinatal morbidity and mortality, either as a direct cause or as an indirect cause. So if you see the cutoffs which are told by WHO in different age groups, at the moment we are basically concerned with the pregnant women. So I have already told you that during pregnancy for normal hemoglobin, the cutoff is 11 gram %. So if the lady is having more than 11 gram %, she is normal. But if she is having less than, then we have to be worried about. You can see lower down in the slide, this picture. Now this is so scare RBCs present in the general blood picture. But if in normal pregnant patients, normal hemoglobin, you will see that the general blood picture is full of RBCs. In anemic, the RBCs are scattered very rarely. Coming to the causes of anemia, I have already told you that the nutritional anemia and the iron deficiency in anemia is the commonest cause during pregnancy. Hookworm infestation, vitamin A deficiency, malaria, which will lead to the hemolysis, other vitamin deficiency like vitamin B12, B6, vitamin E and vitamin C, and the folic acid, all these basically are the part of nutritional anemia. But predominantly, iron deficiency is the commonest. Due to the infections, there can be anemia. Due to the chronic diseases, and among the chronic diseases, renal failure is one of the commonest. So, if you see the causes of anemia, besides iron deficiency and these vitamins, folic acid, especially vitamin B12, if there's chronic blood loss because of the parasitic infection, we were talking about the hookworm infestation. So this this malarial parasites forms one of the very important cause for the chronic blood loss. Then there are certain conditions because of the pregnancy, like multiparity. the lady has got too many pregnancies, then naturally her body stores are not replenished. Then if she is having twin pregnancy, naturally if there are two fetuses, so the iron requirement will be more. And most of our lady in India are predominantly deficient in iron stores before they land up in the pregnancy. So with the twin pregnancy, the chances of anemia becomes more. As I was talking about before also when we were discussing the pre-test, acute blood loss, either in the form of antepartum or the postpartum hemorrhage, again forms one of the very important causes. Recurrent infections, especially renal infections, because we know that the erythropoietin, which is one of the important hormone, is secreted from the renal parenchyma. So if the erythropoiesis does not occur because of the recurrent UTI, then anemia is the result. Then hemolytic anemia, especially in cases of pregnancy-induced hypertension, preeclamptic toxemia. Then at certain geographical belts, hemoglobinopathies are very common. Thalassemia, sickle cell anemia. And so these are also causes for anemia in pregnancy. Especially, I would like to comment on the thalassemia because the general blood picture and most of the parameters are very common with the iron deficiency anemia. A lot of times we get confused because that is again a macrocytic anemia, macrocytic hyperchromic. So thalassemia is also one of the very important cause of anemia, especially in certain geographical belts. Aplastic anemia also forms important cause, but comparatively during pregnancy it is rare, but we do come across pregnant ladies who are having aplastic anemia. Now coming to the clinical presentation. Now, as you know, what is anemia? Basically hemoglobin deficiency, if there is there, then oxygen carrying capacities to the tissues decreases because of the low hemoglobin. So all those presentations where we have got tissue anoxia, etc., we will be having problems, and the result of clinical signs and symptoms will be there. So basically the clinical presentation depends on the severity of anemia. If the patient is having severe anemia, like less than 7 gram%, the chances of clinical presentation will be higher. If she is having mild anemia, like between 10 to 11 gram%, patient at times becomes asymptomatic and we get confused with the normal pregnancy symptoms with the symptoms of anemia. So these are the high-risk women, adolescent, multiparous, multiple pregnancy, lower socioeconomic status. All these are the high-risk women where anemia is more common. I have already told that mild anemic patients are asymptomatic. Otherwise, you can have pallor. She can complain of weakness, fatigue, dyspnea, palpitations, swelling over feet and body. And mind it, at times, weakness, palpitation, and swelling over feet may be the signs and symptoms of pregnancy itself. If you see the signs, pallor, facial puffiness, raised jugular venous pressure, tachycardia, tachypnea, means high respiratory rate or high cardiac rates, crepes in lungs and bases. These usually occurs when she is having very severe anemia. Hepatosplenomegaly, because this is a compensatory mechanism to increase the erythropoiesis, pitting edema over abdominal wall. All of you must have come across the females having very huge pitting edema over the anterior abdominal wall and legs. At times, you may have hemic murmur and cardiac failure. So you can imagine that all these signs and symptoms make you confused with the heart disease, with the liver disease. So with the right heart or the left heart problems, having clefts in the lung bases, hemic murmur, you may think of valvular heart disease. So the first and the foremost important thing, whenever patients complains of these things, you should first check for the hemoglobin. Because I have already told you for the erythropoiesis, not only iron is important, but along with that, The nutritional anemia consists of so many other deficiencies. B12 is one of the very important. And this gives rise to other symptoms of glossitis, stomatitis, chelosis, and brittle hair. So these are general signs and symptoms which anemic patients will show depending on the severity of the anemia. Now, after all, anemia decreases the oxygen carrying capacity, so it will have adverse effect on the mother as well as on the growing fetus, and not only this, even on the neonate. So let us see what are the adverse effects of anemia on the pregnancy itself and on the mother. So there are higher chances of pregnancy complications, especially preeclamptic toxemia, abruptio placentae, and the preterm labor. And whenever the hemoglobin is less, oxygen carrying capacity will be less, and she will be more prone to infections, urinary tract infection, even after delivery, puerperal sepsis. They will be, because tissue anoxia will be there, so there will be higher chances of postpartum hemorrhage, because uterus will not be that contractile. There will be sub-involution of the uterus. Even the lactation will be affected, and the lady may have lactation failure. She might not be able to produce milk and will not be able to feed the baby. And if there is severe anemia, then the effect may be very severe in terms of higher chances of maternal mortality, because it presents as congestive heart failure, there will be cerebral anoxia, there will be high chances of sepsis. And as you know that pregnancy is a hypercoagulable state, so chances of thromboembolism will further increase. So these are the adverse effect on the mother and over the pregnancy. Now coming to the adverse effects on the fetus, growing fetus. There will be higher chances of abortions, preterm labor, intrauterine growth restriction, even IUD. And at birth, the fetus, the newborn will be having low Apgar score. The neonate is more susceptible to anemia also. And there will be higher chances of perinatal morbidity and mortality. Naturally, as in the adult, if hemoglobin level is less, if in the neonate hemoglobin level is less, then the cognitive and the affective functions will also be hampered. The child, as the child grows, will be difficult for learning, will not have that attention span, slow in the class, the IQ will be affected. So just a simple anemia may give rise to so many adverse effects on the mother, on the growing fetus, on the neonate. And what is the most critical period of pregnancy where anemia is maximally affect the pregnancy? The first is 28 to 30 weeks of pregnancy. And why it is so? Because we know that there is disproportionate rise of blood volume as compared to RBC volume. And that is maximum at 28 to 30 weeks of pregnancy. So the hemodilution is maximum at 28 to 30 weeks of pregnancy. And this gives rise to maximum anemia, maximum low hemoglobin at 28 to 30 weeks of pregnancy. Now, labor is another situation because it is a stressful condition during labor, and that makes the chances of congestive heart failure and patients going into failure is maximum during labor. And the second is immediately after delivery. Why immediately after delivery? Because the uterus contracts and suddenly the preload over the right side of the heart increases. Suddenly a lot of blood gushes into the right side of the heart. And this makes the right heart failure. And patient develops congestive heart failure. So this is again very important period. Whenever you deal with the severe anemia, you have to be very careful immediately after delivery. And that is one time when you have to give IV Lasix. Early puerperium, because hemoglobin is less, the chances, all the surfaces, inner surface of the uterus, the vulva, everything is raw, and the chances of infection increases. So that is the time when the chances of sepsis is maximum. So starting for the heart failure, up to the sepsis and the lactation failure. So early preparium again becomes very important. Am I audible and everybody is listening and able to understand?
Yes, ma'am, audible.
Thank you. Now coming to that, so this was the how the patient presents, what are the signs and symptoms. Now coming to the management. Management will depend what is the gestational age. So we have divided management into 4 categories. The first is first trimester. Here we have shown from 14 weeks onward. I have already told you that in the first trimester, we do not give IV iron. The oral iron as such is not contraindicated. There is no such report that it affects organogenesis. But as we all know that in the first trimester, a lady is having a lot of nausea and vomiting, and iron itself causes gastritis. So for the women, it might not be possible to take oral iron. So if patient is having, we have to improve with the diet, counseling, and the diet and nutritious food. But if she is having severe anemia, then we have to give blood transfusion as far as the first trimester is concerned. Now coming to the 14 weeks onward, based on whether the hemoglobin is less than 7 or between 7 to 10. If it is less than 7, we have to evaluate what are the clinical signs and symptoms, how is the pregnancy progressing, and then in this phase, we have to give blood transfusion. If it is between 7 to 10.9, means either moderate or severe. The mild anemia is between 10 to 11. Moderate is between 7 to 10. To be more precise, 9.9. 7.1 to 9.9. So if she's having hemoglobin more than 7 grams, then you can start with the therapeutic oral iron. And what is the dose? 100 milligram of elemental iron along with 5 milligram of folic acid to be given twice a day. Because as we know that the requirement for the iron increases during pregnancy because of the growing fetus, because of the hemodilution. So even if the lady is having more than 11 gram%, we give 1 tablet of 100 milligram of elemental iron with 0.5 milligram of folic acid or 500 microgram of folic acid as a supplemental dose. So if she is having less than 11 gram% of hemoglobin, then we have to give therapeutic dose. And for that, we have to give same dose twice a day. At times, you can give even thrice a day, but usually because these women are not able to tolerate, so therapeutic doses are given twice a day. And then we have to monitor the hemoglobin, but mind it that if you start doing hemoglobin immediately after giving the drug, after 3-4 days, you will not get the result. So at least you have to wait for 3 to 4 weeks. And you know that we are talking about 14 weeks onwards, so you have got time. And as far as her symptoms are concerned, if clinically she is improving, you do not have to bother as far as what is the hemoglobin level. Do it after 3 to 4 weeks, and then you will find the increase in the hemoglobin level. Along with the iron and folic acid, please remember that you have to give 1 tablet of vitamin B12 and 1 tablet of vitamin C, because B12 or the multivitamins like zinc, magnesium, all these things are very important for the proper erythropoiesis, and vitamin C is very important for absorption of oral iron. So it is very important to remember in an anemic patient, if you supplement only iron, the hemoglobin will not increase. You have to supplement along with the iron, B complex, multivitamins, vitamin C. Folic acid is an inbuilt in iron tablets. So remember, folic acid, especially B12 and vitamin C are very important. Multivitamins will help in giving other minerals which are important for erythropoiesis. Now coming to further onward in the gestational period from 16 to 32 weeks, we can divide it into three parts. If the hemoglobin is less than 7 or hemoglobin is between 7 to 9 or hemoglobin is between 9 to 11. Although the cutoff for mild anemia is 10 to 11, but we have divided we have kept these three categories: less than 7, 7 to 9 and 9 to 11. Now how to manage this? If less than 7, whether it is 16 to 32 weeks, 32 to 36 weeks, or more than 36 weeks, in all these conditions, we have to give blood transfusion. Although if she is nearer to 16 weeks, instead of blood transfusion, we can think of giving parenteral iron, IV iron sucrose. But as she is nearing towards term, because we have less time, so instead of giving IV iron, we'll prefer in cases of severe anemia to give blood transfusion. And if you are giving blood transfusion, it is better to give packed RBCs. If you do not have packed facility of packed RBC, you can give whole blood, but you have to be very careful during transfusions. Now coming to 7 to 9 gram percent. In all these three categories, 16 to 32 weeks, 32 to 36 weeks, or more than 36 weeks. In the earlier gestational period, you can even give oral iron. Or if she is not tolerating, then parenteral iron. From 32 to 36 weeks, because now she is nearing towards term, toward 36 weeks, and we know that in an anemic patient, chances of preterm deliveries are higher. So based on how much is the hemoglobin, if it is nearing to 7, it is better to give IV iron, because then you know that compliance is there and tolerance is taken care. If it is beyond 36 weeks, you can give IV iron sucrose, but depending on the other obstetrical factors and depending on the clinical conditions, you might prefer to give blood transfusion. So based on clinical situation, her past obstetric history, her present signs and symptoms, you have to decide whether IV iron or blood transfusions. Now coming to 9 to 11 gram percent. In an earlier phase, between 16 to 32, you can give therapeutic oral iron along with the supportive medication, which we have already discussed in form of folic acid, vitamin B12, and vitamin C. Between 32 to 36 weeks, again oral iron with supportive medication. And what is the dose of oral iron? Can anybody tell? It is to be given twice a day, 100 milligram of iron with 500 microgram of folic acid twice a day. So therapeutic oral iron is to be given twice a day. More than 36 weeks, again, between 9 to 11, depending on how much nearing she is towards term, you can still give oral iron and supportive medication. Suppose she is 38 weeks, she has got 9, it is better to give IV iron sucrose. But depending on the facilities, depending on her clinical conditions, you can decide. As far as the parenteral iron is concerned, we'll discuss in detail. It can be given at the interval of 2 to 4 days, means alternate day or twice a week. So if we summarize the intensified national guidelines, it tells that hemoglobin is less than 11 gram percent is anemia, whether it is a mild and moderate or severe, means less than 7 or more than 7. So based on this, if it is less than 7, and if it is very, very severe, means less than 5, between whether less than 5 or between 5 to 7. If it is less than 5, there is no question of thinking, you have to hospitalize the patient. If it is between 5 to 7 and you are working at PSC level, then please refer the patient to FRUs or the district hospital for IV iron sucrose or ferrous carboxymaltose. This is again one of the iron which can be given by IV route. And if she is in the third trimester having hemoglobin between 5 to 7, she has to hospitalize. Now coming to the mild or moderate, where the hemoglobin level is between 7 to 11 gram per percent, depending on when you have detected it. In the early pregnancy after 14 weeks, you can keep on the iron and folic acid. If it is detected in later pregnancy, you should give IV iron sucrose or FCM, and follow up depending on how much time you have in hand. Improvement occurs, follow after 1 month, do hemoglobin levels and find out if the hemoglobin level is improving, it is good. If hemoglobin is not improving, it means there may be something else also. Maybe having refractory anemia, maybe having chronic infection because of the chronic infection, or some renal problem, or maybe hemoglobinopathy. So in all these situations, if the hemoglobin, even after giving oral iron or IV iron sucrose, it is not improving, please refer the patient to FRUs or district hospital. Now coming to, this is one of the very important things, everyone has to learn how to give IV iron sucrose. It is very simple. The only thing is you have to be a bit careful. You have to be careful before you transfuse IV iron sucrose. Assess her vitals. Take the pulse, take the blood pressure, ask her to pass urine, ask her to be comfortable. Prepare your emergency tray, which contains, we have already told you when we were discussing the answers of the pre-test, adrenaline, hydrocortisone, Avil and oxygen, with all the facility of cardiopulmonary resuscitation. Why I'm saying so? Although there is hardly any chance of anaphylactic reaction with IV iron sucrose, but still, even if it occurs 1 in 10,000, you should be prepared, because you are in the periphery, and if anything adverse happens, then your morale is down and you will not be, you feel that probably you will not be able to give it. So it is better to take all the precautions, take the vitals, be prepared with the emergency tray, and then you have to give. Now what are the other precautions which you have to take? You have to give 200 milligram of iron sucrose in 100 milliliter of normal saline. Now check your ampules, that in one ampule how much iron sucrose is there, whether it is 50 milligram or 100 milligram. So based on that, you have to take so many ampules. Like if it is 50 milligram in one ampule, or if it is 20 milligram in one ampule, then to make 100 milligram, you have to take 5 ampules. To make 200 milligram, you have to take 10 ampules. If it contains 20 milligram in one ampule. If it contains 50 milligram in one ampule, then to make it 200 milligram, you have to take 4 ampules. Now, another important thing, so take 100 milliliter of normal saline and add 200 milligram of iron sucrose. Now, it has to be given in a fast rate, with the fast rate. Should finish between 20 to 25 minutes. But the initial dose, about 10 to 15 ml, to be given in a slow form for within 5 minutes, so that in case any reaction occurs, you are able to manage it. So the initial transfusion for about 5 minutes with 10 to 15 milliliter of that solution is to be given, and later on it is to be transfused with a rapid rate. Within 20 minutes it should finish. After you have transfused, again check the blood pressure, pulse, her respiratory rate. Ask her to lie down for about half an hour, and then you should ask her, she can go home. So this can be given, IV parenteral iron can be given even in the OPD basis. If you have got patients in the wards, you can just in one ward, you can have 4 or 5 patients. Please take one of the staff nurse with you, or one of the interns, or your colleague, and then you can give to all those women who are having anemia and you want to administer IV iron sucrose. So you can monitor them there in one ward and simultaneously can give to 4 to 5. You start with the one, then go to the second, then go to the third. And in this you can have a check on the general condition, etc. on all the 5 patients. Now, this intravenous iron formulation which is used, I've told you that it has to be given with the rapid administration. Now we are talking about iron carboxy maltose. Now this is a bit costly injection, comes about 1800 rupees or 2000, and in one dose it has got 1000 milligram, and it is again to be given IV within 15 minutes. So it does not cross react with dextran antibodies and does not need administration of any test dose. The serum ferritin levels reported to normalize within 3 weeks. So it has got less iron toxicity. The only thing is it can be very safely given in the postpartum period. But as far as the antepartum period, it is being given, but still we need robust data. We do not have that robust data at the moment. So depending on your own judgment, your own advisory for your facility, you can administer even antenatal iron carboxy maltose. So now how the response occurs in terms of hemoglobin rise. If you have, whether you have given oral or IV parenteral iron, the rise of hemoglobin occurs with the rate of 1 gram per week. But you should wait and do the repeat hemoglobin after 3 weeks. You can have increase in reticulocyte count in 5 to 10 days, and the clinical symptoms will improve as the hemoglobin improves. The formula which we have already discussed, that to calculate the iron dose, total iron deficit in milligram means, suppose she has got 7 gram hemoglobin, so and the target is 11, so the deficit is 4 gram. Then body weight in kilo, multiply it by body weight in kilogram, this target hemoglobin and actual this deficiency multiplied by body weight in kilogram. Suppose 50 kg lady, so multiply this 4 by 50, multiply it by a constant 2.4 and add 1000 milligram for the stores. So ideally you should take pre-pregnancy weight, but if you do not have pre-pregnancy weight, you can take the weight in the first trimester, or if you do not have, you can take whenever the lady comes, and depending on whether she's in the second trimester or third trimester, you can have your own judgment that how much weight gain she might have had. You can have discussion with her and can have an approximate idea of her first trimester or pre-pregnancy weight. Now coming to the side effects. As such, I have told you that there are no side effects. Anaphylactic reaction is very, very rare. There may be some milder side effects in the form of skin rashes, arthralgia, joint pains, low-grade fever, etc. may occur. These are all very rare, but you should know, and if patient complains, you will be able to counsel. If she has got a skin rash, you can give Avil injection, you can give hydrocortisone. If she has got anaphylaxis, please give hydrocortisone, Avil injection, and injection adrenaline. Now coming to the blood transfusion. Again, it is very important to know when to give blood transfusion. So the basic rule is, if she is a case of severe anemia less than 7 or very, very severe anemia less than 5, you have to hospitalize the patient and you have to give blood transfusion irrespective of her gestational age. But besides this, if the severe anemia, you have seen anemia for the first time after 36 weeks of pregnancy, then as you have very less time, you have to give blood transfusion. If she has got acute blood loss in the form of antepartum hemorrhage or postpartum hemorrhage, these situations also you have to give blood transfusion. If she has got associated infections, In this situation again, you have to give like puerperal sepsis with severe anemia, 8 gram also with puerperal sepsis. In these situations, you have to give blood transfusion. Another important indication is if she's not responding to the oral and the parenteral threat, then probably blood transfusion will be needed. If patient is anemic and symptomatic, dyspnea with heart failure, irrespective of the gestational age, because if she's a case of severe anemia less than 7, not all the patients, but a lot of patients present as congestive heart failure and decompensation. So in these cases, irrespective of the gestational age, blood transfusion will be needed. So these are few guidelines for the blood component therapy. As I have told you that hemoglobin is not the only deciding factor for the blood transfusion or component therapy, but her signs and symptoms, her gestational age, all these are very important. As I've told, if she has got less than 7 gram %, there are signs and symptoms of impaired oxygen transport, in cases of sickle cell or iron deficiency anemia, you have to give blood transfusion. If the hemoglobin is between 7 to 8, but she needs surgery, like you are taking her for cesarean section, or you are taking her for MTP, or she is bleeding, having abortion. So she again needs, because here the blood loss will be more, so you need blood transfusion. If between 8 to 9, especially in patients of chronic transfusion, like if she is a case of thalassemia and used to have transfusions, in these cases, probably you will need blood transfusion. If the hemoglobin is between 10 or 11, usually it's not likely to be appropriate to give blood transfusion unless there are some specific indications. And what can be the specific indication? If this sudden blood loss, the more than 30 to 40% of the total blood volume has lost, in antepartum hemorrhage, in postpartum hemorrhage, during delivery, or during abortions. If she has got sudden blood loss, she may be a case of vesicular mole and has got severe blood loss. In this situation, even if the hemoglobin is between 10 to 11, but because the blood loss is more than 30 to 40% of the total blood volume, so in these cases, she will need blood transfusion. So this we were talking during antenatal period, what will be the clinical signs and symptoms, how to diagnose, how to manage, when to give blood transfusions. Now coming to the labor, as we know that labor is a stressful condition, and if patient is already anemic, again depending on the severity, the decompensation may be very rapid. So you have to be very careful. And at times you have to, again based on the severity of the anemia, you have to treat these patients just like a heart disease patient. So the labor, these women have to be counseled that it should be an institutional delivery. It should be a supervised delivery. Proper consent to be taken, and a lot of counseling is needed. We cannot allow the patient in the first stage of labor to be ambulatory. She has to be lied down. Not only lied down, but her head should be slightly propped up position. This is what you do in the heart disease patient. Then you have to give intermittent oxygen, because you know that her hemoglobin is less, the oxygen carrying capacity is less. At the moment during labor, she is having uterine contractions. You need more oxygen. So intermittent oxygen to be given. Because of anemia, she is more prone for infection. So one has to take all the precautions for infection prevention. The repeated PV examination to be avoided. Hand washing, wearing the glove, all these are very important, especially at the moment present COVID era. So strict aseptic precautions and minimal PV examination is the rule. Prophylactic antibiotic to be given. You can give 2 grams of injection ampicillin or ceftriaxone depending on whatever is available with you. IV line should be patent. We do not need to give a fluid transfusion, but for the patency, an IV drip has to be given, and a very slow IV drip, maybe 75 ml per hour, is to be given, because in case if she decompensates, you have got a patent IV line, and so that any drug which is needed can be given immediately. As I have told you in the very beginning, if decompensation occurs, immediately IV furosemide, Lasix to be given. Otherwise, we do not give diuretics. For the second and third stage of labor, for any high-risk pregnancy with the anemic patients, the second and third stage to be cut down. So the second stage can be cut down with the forceps or ventouse based on whatever modality you are more comfortable. For the third stage of labor, active management is to be given, means massaging the uterus, giving intramuscular oxytocin 10 units, then delivering with the brand-induced technique, the placental delivery, and then massaging of the uterus, all the same as you do with any other pregnancy. One precaution to be taken. We do not recommend it to give IV methergine. Why? Because if once you give IV methergine, within 45 seconds, it acts over the uterus, and uterus suddenly contracts uterine musculature. So what will happen with the sudden contraction of the uterus? All the blood will go into the right side of the heart, and she will immediately become decompensated in the form of congestive heart failure. So the same is true for the heart disease patient. So in both, severe anemic patient behaves absolutely like heart disease patient, and we do not recommend IV methergine in both the situations. In severely anemic patient, after delivery, IV furosemide to be given to decrease the cardiac load. Another important thing which in the older days was practiced, like after delivery, the lower limb to be hanged below, so that pooling of the blood occurs in the lower limb and it does not go by the uterine contraction to the right side of the heart. So this is one precaution which you can take. Instead of doing Trendelenburg position, you should hang the lower limbs down. Now coming to the postnatal care and the contraception. Postnatal care is very important, early ambulation to be encouraged, because in the postpartum period, it is again an hypercoagulable state, and the chances of thrombosis and thromboembolism will be more. So early ambulation is encouraged. Hematinics to be continued, oral iron for 3 to 6 months, depending on how much hemoglobin she was having. You have to watch for the subinvolution of the uterus, for the puerperal sepsis, for lactation failure, because these are all the adverse effects of anemia. Another very important counseling message is that you have to take care of contraception. She should not conceive minimal for 2 years, so that her body organs are they recoup, come back to the pre-pregnancy state, her iron stores are replenished, her lactation feeding is complete, which is recommended exclusive breastfeeding for 6 months and up to the extended period of 2 years, so that she becomes normal, she is able to take care of her next pregnancy. So for 2 years, she should not conceive. And the contraceptions, the various forms of contraception can be given: lactational amenorrhea, barrier contraceptive, progesterone only pill, or even injectable medroxyprogesterone acetate, Antara, which we have got now. After 6 weeks, we can start. IUCD, even postpartum IUCD, within 48 hours can be given. If she has not got any infection, she is not having severe anemia, there are no chances of chorioamnionitis. Then postpartum IUCD can also be given. So thank you very much. I really enjoyed interacting with all the participants. I hope आप लोगों को समझ में आया होगा. एनीमिया बहुत सिंपल टॉपिक है लेकिन बहुत इम्पोर्टेंट है. दिस इज द कॉमनेस्ट मेडिकल डिसऑर्डर जो कि हमें प्रेगनेंसी के दौरान हम we come across and we have to manage.
So thank you, Vinita ji.